Dr. Shankar Narayanan, and I'm going to talk to you today about the total hip replacement and why I firmly believe that it is the operation of the century. Just a couple quick housekeeping issues. Number one, you guys are all muted, and if you do have any questions or if there are any technical difficulties or any issues, please type in the chat box. All of the questions will be answered at the end. Lastly, this is being recorded, so if you would like to go on YouTube tomorrow or in the future, and if you type in OrthoCincy in YouTube, you will be able to see a link to not just my recording about hip replacement, but all of the recordings that all of the physicians have done over the past several years about different surgical procedures. Without further ado, we'll get started. I don't have any disclosures. I don't have any financial disclosures, conflicts of interest, and all of this is meant to be educational. Real quick, who am I? Well, I am a board-eligible orthopedic surgeon. I've specialized in hip and knee replacement surgery. I am born in Cincinnati, or I was born in Cincinnati, Ohio, in 1988, so born and raised. Neither of my parents were physicians, and I did grow up always kind of wanting to study medicine ever since high school. I did go to St. Xavier High School. I then matriculated at Ohio State University, where I got my bachelor's in 2010, moved back to Cincinnati for a couple of years, worked at Children's Hospital, and then went to Wright State University up the road in Dayton for medical school. Did my residency back in Columbus at Ohio State, where I met my lovely wife, as you can see in the bottom right-hand corner, and I finished in 2021. We both moved to New York and did our subspecialty training in both hip and knee replacement surgery at New York University in Manhattan, and then moved back to be closer to family and closer to friends as well. And I'm really excited. We're welcoming the birth of our first son in June, so a couple months away. A couple quick goals and objectives. The goal is really to discuss total hip replacement and eventually to have a discussion with you and or your loved ones about hip replacement surgery. So very basically, what is the actual hip? The hip is a ball and socket joint that is located in your pelvis. And a lot of people, when they either break their hip or they're having difficulty walking or something, they don't really understand that the femur is actually part of the hip. So the thigh bone, as you can see right here, comes all the way up here and forms the hip. This entire joint right here is the actual hip, and it's surrounded by a very thick joint capsule and is made up of different portions of the femur specifically. Different names, just like the names of the body itself. You have a head, which is here, a neck, right there, and you have a shaft, which is right there. This particular area is called the intertrochanteric region. There are two bumps here and a bump here, and occasionally, older patients can suffer fractures through here. But what we're here to talk about is mainly hip replacement. And what that entails is actually replacing the ball and the socket of the hip. So what is arthroplasty? Like we said, it is replacing or a surgical repair of a joint or creation of an artificial joint, which you can do in multiple different joints, but the most common ones are the lower extremity weight-bearing joints of the knee and hip and the shoulder in the upper extremity. What is osteoarthritis? Well, osteoarthritis is a degenerative joint disease that was founded all the way back in the 1700s by an old physician named William Eberton. And he published about it while he was in London. And what he noticed is that patients sometimes will get these nodes on their fingertips. And of course, he named them after himself. But you can get arthritis anywhere in just about any joint of your body. And it's a degenerative joint disease that attacks your cartilage and will completely destroy the cartilage and render your joints in difficulty with range of motion, and sometimes even difficulty bearing weight. So getting into some of the history, which is something that I really like and enjoy, a guy by the name of Dr. Smith Peterson was the chairman at Harvard University in orthopedic surgery. And he learned under some of the most prominent surgeons in the country and in the world as he emigrated from Oslo, Norway. And when he was assisting a senior surgeon by the name of Roy Abbott on a kid's hip dislocation, they used the posterior approach to the hip, as you can see here. And what they did was they had to take down a lot of muscle and split the muscle in order to get to the hip. And Dr. Smith Peterson actually asked Dr. Abbott, that we lost a lot of blood. There must be a better way to expose the hip joint in order to do surgery on the hip. So Dr. Smith Peterson actually was the first surgeon to develop the anterior approach to the hip replacement. And what he actually did was, instead of totally replacing the hip, is he used these molds of Pyrex glass. And what he would do is he would just put them right over top of the femoral head. And what would happen is that they would create this inert foreign body reaction so that you could have a smooth gliding surface instead of bone rubbing against bone. And he coined this as the mold arthroplasty. And this is a picture of the Pyrex mold that you see here on the right-hand side. He implanted hundreds of these, and he used something called Vitalium mold, or cobalt chrome, which is something that we use today in our arthroplasties, except he used it basically as an interposed covering between the femoral head and the actual acetabulum. And you can see a picture of that right here in his landmark paper from 1947. So real briefly, this was actually a discovery that came all the way from Dr. Scott Venable, who was actually the dentist for Dr. Smith Peterson. And he developed this in hip replacement surgery using the Vitalium, or the cobalt chrome and molybdenum. Fast forwarding to the 1960s, there was something called low friction arthroplasty. And this gentleman, Sir John Charnley, is truly the pioneer and the founder of modern total hip arthroplasty. And he was born in England, and he was a really, really intelligent guy. He was kind of one of those guys that didn't totally excel in what the English call primary school because he wasn't really stimulated. But once he got to medical school, he graduated at the top of his class, and he always wanted to go into orthopedic surgery. And back in the 50s, orthopedics was primarily a study about bones and joints and infections that happen in children due to tuberculosis and polio. But he eventually got very interested in joint replacement when he learned of a patient who had had a hip replacement but had a lot of squeaking, because that's what happened when you had some of these previous arthroplasties or coverings that were done prior. So what he did was, around the late 1950s, he was introduced to something called PTFE, or simply Teflon. And he saw that it was an inert plastic. And what he realized was that in hip replacement, it's not just the ball that goes bad, but it's the socket that goes bad as well. And he needed to create some sort of low friction mold almost that would let the ball and socket rub against each other without causing pain. So he used PTFE or Teflon as his low friction surface, and then used a stem, a cobalt chrome stem with a cobalt chrome head in the hip. And he did his first surgery in 1961 and published it in the Lancet. And what he actually did was, in order to get to the hip, he actually cut the bone and the muscle, got into the hip joint, cut it right here like we do today, cemented in the PTFE or Teflon liner, and then reattached the trochanter with wires to the bone and cemented in this stem. It was all one piece. It wasn't modular like we have today. The post-op protocol was very different than what we have today, where patients were actually placed into a plaster cast for 3 weeks and were on bed rest for near 6 weeks. He did his surgery at the Hip Center at Wrightington Hospital in England, and he was able to deeply study all of these patients. And what he actually found out was that some of these patients had some failures, so they had to change up the actual plastic that was used, and we'll get to more on this a little bit later. Part of the reason that metal-on-metal prostheses were discovered was because Dr. Charnley had failures with patients that had PTFE sockets. And Dr. Ken McKee and John Watson Farrar were English orthopedists that developed metal-on-metal hip replacement. And what they did was they cemented these components into place into the hip. And what you can see is here, they actually used a different approach, an anterolateral approach to the hip, to get into the hip and resurface the acetabulum with this metal and place this unipolar monoblock stem with a head in place into the femur. And those worked decently well, but they also had failures because, as we know, some metal-on-metal hip replacements had a lot of failure, specifically early in this part of this century, which we'll talk a little bit more about. And now we're getting to cementless total hip arthroplasty, what we're doing right now. And this was founded really by the guy by the name of Bill Harris. He was a very, very smart gentleman, was the chair at Harvard University for orthopedics for quite some time. And what he actually realized was that these parts in hip replacement surgery need to be modular. What does that mean? They need to have multiple different parts. You need to have a socket made of cobalt chrome, whether that is cemented in or press fit in. You need to have a piece of plastic that you can lock into the socket, that you can change out if needed. You need to have a separate head that you can put on the stem in the femur in case you need to change those out. And all of that was how we got to the modern total hip replacement today. The biggest thing he said, the key issue is replaceability. The ability to introduce a new plastic component without having to remove the old socket. And so now what we're seeing with these different bearings are we're seeing different plastics that were being used. Part of the reason that hip replacement surgery, people would tell you that it only lasted 10, maybe 15 years, was because the plastic would wear at a very high rate, as you can see here. The older plastics would wear at 200 microns per year. Nowadays, the newer plastics, which were founded by Dr. Tom Schmalzried and Bill Harris in around the year 1999 and 2000 was when they were really first introduced. We have only seen maybe 20 microns per year. Really, in some of the new plastics that we see 0.01 millimeters or micrometers actually per year of wear in both hip and knee replacements. The plastics have come a very, very long way, and the durability of the plastic is why we now have hip replacement surgery that can last a very, very long time. As you can see here, metal on metal hip replacement was a big thing in the 90s and the early 2000s. However, the issue with metal on metal hip replacement is that what would oftentimes happen is patients would develop pain, and what we would see is that the metal ions would wear and they would develop pain, and sometimes they would develop a big fluid collection because of the wear of the metal against metal. So we have gone against metal on metal components. And so what do we see? Well, metal on metal wasn't very good. Metal on polyethylene is pretty good, but we used to see something called osteolysis, where the bone was actually resorbed. Ceramic on ceramic has a low wear rate, but we saw squeaking. And now we get to ceramic on polyethylene, which is what we are seeing now and what we are doing now and is the standard of care now in 2023 in hip replacement surgery. So let's get to the bread and butter of this topic, modern anterior hip replacement. The modern anterior hip replacement was really brought to light by Dr. Joel Mata roughly in 2005, and he actually learned this from one of his contemporaries in Paris, France. And what he did was he used an old table that his predecessor, Emile Letournel and Jean Joudet, used to replace the hip. It's a table that you guys will probably see if you ever have an anterior hip replacement, and it's simply called the HANA table. And you can see a picture of it right here. And it's a table that uses ski boots. And what it does is it allows us to place your hip or place your feet in these ski boots and do an anterior approach to the hip. And what that entails is doing an incision in the front of the hip instead of on the side of the hip. And what that is it's a muscle sparing approach. What we do is we incise in the front of the hip and separate the muscles off the hip capsule, remove part of the hip capsule, and then proceed with our normal hip replacement surgery. One of the things that Dr. Mata found when he looked at all of his patients that he did anterior hip replacements on was not only did he see a very, very low dislocation rate, meaning the ball coming out of the socket, but he actually saw patients that were recovering so much faster because we weren't cutting the muscles, because we were splitting the muscles, going in between the muscles and removing part of the hip capsule and going through the front in order to replace the hip. And this is just a patent on the table that we use nowadays in order to do an anterior hip replacement. And what we've seen, the results are dramatic. People are leaving the hospital the same day after surgery. People are running, biking. Most of them are walking. All of them generally are walking without an assistive device and without a limp. They are back to doing all of their activities of daily living. They are back to doing things they like and enjoy, like golfing, swimming, tennis. Some will run. A lot of them are doing walks, very long walks. I had a patient that actually just had a hip replacement that walked the Heart Mini Marathon 2 weeks after her hip replacement, and she sent me a picture and she was absolutely ecstatic. People are doing very, very well after anterior hip replacement surgery, and they're getting back to doing all of their activities of daily living. So total hip replacement today, what can you guys expect after total hip replacement surgery or with total hip replacement surgery? Number one, if you are having any groin pain, if you're having difficulty putting on your shoes and socks, if you're having difficulty spreading your legs, difficulty getting into or out of a car, getting up from a low toilet seat, you may have hip arthritis. And what that is, again, like we talked about, is a degeneration of that ball and socket joint. X-rays are the best way to diagnose it, and a hip replacement is ultimately one of, if not the best operation in orthopedics to alleviate patients that have hip arthritis and have groin pain. They have resulted in a very, very high patient satisfaction, a return to a significantly better quality of life. And instead of people using canes to get around, they're ambulating without any assistive devices. Nowadays, we can use modern regional anesthetic to increase your ability to go home right after hip replacement surgery. And all of this has supported Mark Coventry's observation. All the way back in 1991, he actually said that the total hip replacement might be the orthopedic operation of the century. If you guys have any questions, I'll open up the floor right now. If you would like to schedule an appointment or an evaluation for hip replacement with me, you can call my office at 513-232-BONE or 2663. You can ask for Dr. Narayanan. I see patients in Westchester, Kenwood, and in Mount Auburn at the Christ Hospital. You can always go to OrthoCincy.com and you can click on my page, and you can schedule an appointment right there with me via my chart as well. Thank you for your time. We will now move to the question and answer portion of this. One question: who is the typical candidate, and is there an age limit? What I would tell you, the typical candidate for a patient that has hip arthritis is a patient who complains to me of groin pain, pain that is disabling them from putting on their shoes and socks, getting into and out of a car, and really limiting their ability to walk or even walk long distances. Sometimes patients have had a leg length discrepancy and they may notice that. And if they get an X-ray, they would see hip arthritis. There's never an age limit to hip replacement surgery. And nowadays, we are seeing patients that are younger and younger, that are more active, that have hip arthritis, that do very, very well with hip replacement surgery in their 50s. Excuse me. I have had multiple patients come and see me that are in their 50s, that have had hip replacement surgery, that are walking without any assistive device, that said they can go up and down stairs for the first time without taking the steps one step at a time. And they're very, very happy. A lot of people ask, how long does it last? Again, we think that nowadays with the new plastics, it can last 30, 40, maybe even 50 years. In order to determine if a patient needs surgery and to go through the regimen to determine if they need it, the best thing to do is to make an appointment. We get X-rays in our offices. And what I always tell my patients is, if you are at the point where you are unable to do your activities of daily living, or this is significantly impacting your quality of life, then hip replacement surgery may be the best option for you. You will not have any restrictions after surgery. As long as surgery goes as planned, you'll be able to bear full weight, and you should have significant increases in range of motion right away. Are there any differences in recovery for women and men? That's a great question. There are fewer differences in recovery for men and women, but there are differences in recovery for people of different ages and sometimes for different indications. Obviously, if there are larger men who are very active that have significant groin pain and don't walk with any assistive device at the moment, they can generally recover a little bit faster than a frail, maybe elder woman in their 80s who has hip arthritis that ambulates with a walker or a cane and has had this problem for a very long period of time. Generally speaking, though, there are no differences in recovery for men and women. Another question. I was an active adult prior to surgery. Can I expect to return to the same activity level? How long should I expect it to be before I can return to that level? What I would tell you is if you had a hip replacement and the hip replacement was done well and looks good on X-ray, usually patients are getting back to doing dancing. They're getting back to doing all their activities of daily living by about 6 weeks. And by about 3 months, they're really feeling like they're about 95 to 99% better. With good physical therapy, if needed, of course, strengthening any of the muscles around the hip joint can really help get patients back to a full recovery. Another question. Is this something that will wear out over time, and will I need to go through this process again? Another great question. Nowadays, with the bearing surfaces that were found or that were created in the lab with the ultra high molecular weight, highly cross-linked polyethylene, the piece of plastic, so to speak, that replaces your cartilage is so good that their wear rates are so minimal. There is always a chance that it can wear out over time, but the hope is that you won't need to go through the process because the plastic wears out. The chance is that at some point in time, if you have a hip replacement in your 60s, hopefully you don't have to redo it again in your 90s because the implants have grown into the bone and the plastic is actually still lasting and is good. Another question, is this something that will, which approach is better, posterior or anterior? And is it unique to each patient? That is an excellent question. What we have found in our studies is that the anterior approach generally will lend to a slightly faster, earlier recovery due to the muscle sparing approach. However, in some patients, some bigger patients sometimes, it's easier to do a posterior approach to the hip because the anterior approach can have a higher wound complication rate. And that is what we have seen in all of our literature and our studies. The short answer is that it's very unique to each patient, and it's very unique depending on the type of arthritis you have. The hip is a very complex joint, and sometimes patients can have differences that are not your garden variety osteoarthritis, which is a little bit bigger than this talk. So sometimes, yes, it can be very unique to each patient. Next question, how big is the incision? Generally speaking, the incision's about 8 centimeters, sometimes maybe 10 centimeters on the front of your thigh. It can usually be covered by underwear so that people don't see it. And sometimes people can even do a bikini style incision to the point where nobody sees the incision at all. If you have a posterior approach to the hip, generally speaking, your incision will be a little bit bigger, but not that much bigger, maybe 10 to 12 centimeters, depending on the patient's body habitus. Another excellent question. Can I have both hips replaced at the same time? Having bilateral hip replacement surgery is something that I have seen before. It's not, unfortunately, for the faint-hearted. Hip replacement surgery oftentimes can result in a little bit of blood loss. And if you have hip replacement surgery at the same time, you are prone to having a little bit more blood loss. You will probably have to stay in the hospital overnight instead of going home the same day after one hip replacement. And generally, you can be more prone to medical or surgical complications. Can you have them both replaced at the same time? Absolutely. But it's probably best to speak to your orthopedic surgeon and see if you are a good candidate for bilateral hip replacement surgery. The last question I see, I am a runner and a casual hockey player. Can I do both again after surgery? If so, how long is the recovery process? Very, very good question. Short answer, absolutely. I think that you can run, and I think you can casually play ice or roller hockey after surgery. Running can be a little bit more challenging, but I always tell patients, as long as you have a well-done hip replacement, you should be able to run again. The recovery process is usually about 6 weeks. That's what I tell my patients. The first 2 weeks are usually the hardest. I send all of my patients to physical therapy after surgery. Some of them don't need it, but I always try to tell them to have physical therapy so that they can strengthen the muscles around their hip after hip replacement surgery. Usually, after hip replacement surgery, specifically from the anterior approach, patients use a walker for anywhere between 1 day and a week. Very rarely will people use it for 2 weeks. Usually by 2 weeks, they're using a cane. And if some people aren't using a cane, sometimes they're not using any assistive device, and they're very, very happy with it. Usually between 2 and 6 weeks, people are recovering. They're very, very happy, but they're getting to that 99%, maybe 100%, if at all possible. And by 6 weeks, patients are generally very, very happy that they had hip replacement surgery. They're usually walking without any assistive device by 6 weeks. Some of them are doing light jogging if they were before. Some of them are back to dancing and doing sports, getting back in the pool and swimming, and doing all their activities of daily living. Again, thank you guys very much for your time. If you have any questions about hip replacement surgery, you can give my office a phone call at 513-232-2663. You can make an appointment online at OrthoCincy.com. Click on physicians, click on my picture, and make an evaluation or make an appointment for an evaluation for your hip. Thank you very much and have a good night.